Hello, everyone. This is Dr. Weaver. I wanted to go ahead and create the voiceover, the introduction to clinical pharmacology voiceover, more specifically, skeletal muscle, bone and joint disorder drugs, the drugs that we use to manage these disorders, if you will. All right. I'll try to keep this as short as possible. So, without further ado, let's begin. I am sharing my desktop, and it appears to be working well. All right. Let's take a look at the objectives. We're just going up to, all of them are important, of course, but as you all know, we stop just before we get to the pre-admission and ongoing assessment activities. As you all have agreed to take a look at that information yourselves. And as I've always said, it's just pretty much a repeat of what we have already gone over. They just, they put it in the form of the nursing process, which is very important for you to learn and really focus on that because that is one of the main pieces of knowledge that you will acquire in nursing school, and that is the nursing process. Even how we test you as far as your NCLEX is concerned, and pretty much testing throughout. Nursing school is based on the nursing process, no matter what. So list of types of drugs used to treat musculoskeletal disorders, and the second one, explain the uses, general drug actions, adverse reactions, contraindications, precautions, and interactions of the drugs used to treat musculoskeletal diseases. All right, not a whole lot of objectives. All right, so Right. There are many drugs that are used to manage musculoskeletal injuries as well as disorders. Those drugs would include skeletal muscle relaxants, disease-modifying anti-rheumatic drugs, bone resorption inhibitors, and more specifically the bisphosphonates, as well as the uric acid inhibitors. And much of this we have already, I won't say much of it, but you more or less got an introduction to these drugs when we discussed the med surge part of this. Um, these disorders. So thankfully you have had some exposures to these medications already, which should make it a little easier, I would say. All right, and some of this we've gone over in class just before they pulled me out of the meeting. So I'll just go ahead and just start from the beginning again because I'm sure I will be using this voiceover again for future classes. All right. Now, in addition to pain relievers that we discussed earlier, skeletal muscle relaxants are used to assist in relaxing certain muscle groups, such as strains and sprains, which also helps to repair themselves. Need to expand my speaker notes. As far as actions as it relates to skeletal muscle relaxants, the mode of action of many of the skeletal muscle relaxants, such as the carisoprodol, carisoprodol, I guess that's the way you pronounce that. Baclofen, that's an easier one, and chlorozole Zaxone. Their mechanism of action is not quite known. All right. Many of these drugs they do not directly relax skeletal muscles, but their ability to relieve acute pain for musculoskeletal conditions might be due more so to their sedative action. So the ability to make one sleep, if you excuse me, if you will. Um, One of the drugs in particular is the cyclobenzaprine, or you guys probably know it as Flexeril. It does appear to have an effect on muscle tone, and thereby reducing muscle spasms. That's probably the only one that I know of. Now, the exact mode of diazepam or Valium, which is used as an anti-anxiety drug in relief of painful musculoskeletal conditions, is also not known, but it seems to help. The drug does have a sedative type of action, which may account for some of its ability to relieve patients who experience muscle spasms and pain. I just think that any drug that can help you to sleep, all right, will affect your muscle tone anyway. Because one thing about it, you're not really thinking about much when you're sleeping, right? You don't even know you're in the world when you're sleeping. It's almost as if one is dead. Um, anyway, as far as let's see, as far as uses, this these drugs are used for painful musculoskeletal conditions, for example, muscle strains, as well as back pain, where there's a lot of muscle spasms, which is what causes the pain. Also, preoperatively to relax just before surgery, it helps to relax muscle tone throughout the body and all specific muscles. Now, of course, this can help in or aid in intubation. You know, when you have to stick the tube down someone's throat and place them on a ventilator during surgery. Because it helps them to relax and they're not fighting and bucking your attempt to try to intubate them, which most people will. It also helps for easier movement of joints and limbs during surgery, especially if you have to manipulate the limbs. If it relaxes the limbs, then it's much more easier to perform the surgeries that require such manipulation or movement. Take a look at the common adverse reactions. Drowsiness is the big one, but it also causes sedation, sleepiness, lethargy, but unfortunately can as well cause constipation or diarrhea. Probably one first before the other. Same with bradycardia. One first before the other. You probably get a bradycardia first, and then tachycardia follows, usually. As a compensatory mechanism. And also, it can cause a rash as well. So, given what we know looking at these adverse reactions, we know that we have to caution patients about driving and working around dangerous machinery and climbing ladders and those types of things. It is contraindicated. Or skeletal muscle relaxants are contraindicated in those with hypersensitivity to drugs. That's always a given. Um, Baclofen is contraindicated in skeletal muscles caused by rheumatic disorders because the drug. I mean, if you think about it, the spasms caused by rheumatic fever is not quite the same that would be due to a spinal cord injury or some issues with the brain, and so it's likely not going to act or work the same. Um, the other drug, propadol, is also contraindicated with patients with known hypersensitivity to metprobamate, which is another drug used in the management. I believe this one is used in the management of muscle relaxants as well, but let me double check that one. though. Now, baclofen is primarily effective for treating spasticity. Now, think about spasticity that is caused by central nervous system disorders such as multiple sclerosis and spinal cord injuries. And so that's different than the muscle spasms that people may experience due to inflammation, such as in rheumatic conditions. Now, cyclobenzaprine, or Flexeril is also contraindicated in patients with a recent myocardial infarction. It is contraindicated in cardiac conduction disorders. That's the electrical conduction system of the heart. Also, it should not be given to those with hyperthyroidism. In addition, this cyclobenzaprine should not be given within 14 days of the administration of the MAOIs, or the monoamine oxidase inhibitors. And this is due to the fact that it can cause a hypertensive crisis, meaning the blood pressure will be extremely high. Right. What happens is this Flexeril, or the cyclobenzaprine, it increases norepi levels. And norepi causes everything to go up: the heart rate, the blood pressure, and so forth. Right. Uh, and so what happens is the MAOIs, it prevents the breakdown of the norepi, right? And if the norepi stays in our systems, or it accumulates in our systems for too long, again, it can affect the blood pressure, raising them to dangerously high numbers, which can lead to strokes, severe headaches, and other in organ problems. Because the extreme high blood pressures, it can affect perfusion to our organs, and as well as our tissues. I'm sorry, everyone. And also, just to make sure you take a look at the rest of these medications, just in case they ask you specifically on the exam about them. And also make sure you guys are using the generics as well as the trade name, just in case they pull that number. All right. Now, skeletal muscle relaxants are also used with caution, meaning they can be given, but we just have to be cautious about their use. And those patients who have a history of CVAs, or cerebrovascular accidents, or AKA strokes, cerebral palsy, Parkinsonism, seizure disorders, as well as pregnant and lactating women. Hepatitis is of concern when women and those older than 35 are prescribed dantrolene. Now, the carisoprodol, excuse me, is used with caution in clients with severe liver and disease, and also during pregnancy and lactation. Um, Flexeril is used cautiously in patients with cardiovascular disease, as well as the pregnancy and lactating women. It's a pregnancy category B, which is not as high, but still, again, caution. Then dantrolene is a pregnant category C drug, and it's also used with caution in pregnancy. So as those categories become higher, the ABCD, and I think the ABCD, and I think there's an X. The higher, the more dangerous the drugs are. So I have to be careful. All right, and I'm going to have you guys take a look at the interaction tables. And so, for example, um, CNS depressants such as alcohol, antihistamines, opiates, as well as sedatives. This is why we give it, which is we promote a calming effect. or it promotes a calming effect, or it provides pain relief. But when given with one of these, well, when given with a muscle relaxant, it increases CNS depressant effects. So, for example, breathing is going to be one of the main concerns with these drugs. Right. When Flexeril is given with one of the MAOIs, which we use MAOIs to manage depression, it can cause risk for high fevers and also convulsions. And so you can see, given this drug in combination with muscle, these drugs in combination with muscle relaxants would not be wise nor prudent. So just take a look at the different um, tables, and just in case they test you on it as well. All right. Now the DMARCs, as far as actions and uses. So we use this drug to treat, for example, rheumatoid arthritis or any of the some of the autoimmune disorders, even cancer. Now, rheumatoid arthritis, of course, is something we have already discussed as far as med surge, but it is an autoimmune disorder, right, in which these antibodies are formed against our bodies or against one's own body. Now, as a defense mechanism, white blood cells are mobilized. You guys know what white blood cells do. You know what their action is all about. They fight the enemy. They fight the antigens that are produced. Right. So it mobilizes, or it prepares white blood cells to go and do their job. And so these white blood cells, they lodge in patients' joints. Right. And what this does is it causes swelling, it causes pain as well as inflammation. All right. Now, this condition, rheumatoid arthritis, is typically treated using at least three classifications of drugs. Right. Initially, these patients may just they may just receive NSAIDs, right? But anyway, so the three drug classifications would be your NSAIDs, your corticosteroids, as well as your DMARDs. Now, as far as in the early stages of this condition, as I said, NSAIDs might be used by itself. But then, as this disease worsens, then pain medication and corticosteroids may be used for quick relief. But then the DMARDs are added in order to suppress the immune response, which can control the symptoms that this autoimmune disorder causes. Right. As far as actions and uses, when the patient becomes more immobile, and the pain that is caused by rheumatoid arthritis cannot be controlled by pain relief agents, anti-inflammatory drugs, then DMARDs are going to be used in this case. Now, the most common DMARDs include your methotrexate. Some of you probably heard of that one. The sulfa salazine, your quin, and your leflunomide. Now, these drugs have properties that produces immunosuppression. So you're trying to make the immune system weaker. You're trying to suppress it because remember, it is the immune system that is attacking one's own body. So our goal here is to weaken the response of the immune system, and this will in turn, of course, decrease the body's autoimmune response. All right, we're trying to quiet down that autoimmune response, which is again attacking the individual's body. So in RA treatment, the DMARDs are useful for their immunosuppressive ability. Now, other autoimmune diseases that are treated with these DMARD drugs are your Crohn's disease, which is an autoimmune or is believed to be autoimmune in nature, as well as fibromyalgia. Now, methotrexate, which is also used, which is also a DMARC drug, it is also used in cancer treatment, in which the immunosuppression, because when these drugs are used on anyone, even with cancer patients, it is considered an adverse reaction when rather than its intended effect. So, what is the intended effect, right? So, in simple terms, the methotrexate is a drug that is used in cancer treatment. It works by slowing down the growth of cancer cells. However, one of the results of using this drug is that it can weaken the immune system, making it harder for the body to fight against infections. All right. So the methotrexate, it being a DMAR drug, it does weaken the immune system, but the indications for this drug is to decrease the multiplication of cancers rather. All right. But it has the other consequence or adverse consequence, weakening the immune system in a patient who's probably taken other chemotherapy drugs, which are also weakening the immune system. So these patients are really susceptible to infection because we are manipulating the immune system. All right. Um, Right. Now, there's another drug that is used, they refer to as tumor necrosis factor or TNF inhibitors, right? TNF inhibitors. And these are also used in those who have rheumatoid arthritis and other related inflammatory conditions. Now, so what is TNF? It's also referred to as TNF alpha. This is a small protein, all right, that regulates the body's immune cells, and it brings about the inflammatory response. All right. So why is that important? So what we need to think about in this case is what is the function of the inflammatory system? So the inflammatory system is the body's natural defense mechanism or system, and it plays a crucial role in healing as well as protecting the body from, again, like your foreign invaders or infections, if you will. All right. And um, so being that it basically makes the immune system, that inflammatory system, do something, try to protect the body from disease, if you will, or disease causing things such as, infection or whatever the antigens might be. This protein, it essentially stimulates the immune system to fight. All right. And ordinarily, this is a good thing. All right. Ordinarily. All right. Um, the problem is if the body, if in rheumatoid arthritis, it being an autoimmune disorder, the body is attacking itself. When these proteins are allowed to operate and also make the immune system fight against whatever, right? Then it could also be fighting against the body, and so they give these patients these inhibitor drugs, or the tumor necrosis factor inhibitors, to weaken or to reduce the tumor necrosis factor or its ability to stimulate an immune response or an inflammatory response. All right. We want to inhibit that response. All right. We don't want to, we don't want like an agonist, right? We want, if anything, an antagonist or an inhibitor. We want to stop it. We want to stop that TNF or the tumor necrosis factor from operating. Because the body's already getting beat up by this autoimmune condition, rheumatoid arthritis. And so again, just decreasing uh, or minimizing the impact of the tumor necrosis factor could slow down or reduce some of that inflammation. So the body is not getting beat up as much, if that makes sense. Trying to say it in a way that it would make sense to you guys. Now, these inhibitor drugs are termed also biologic DMARDs, these tumor necrosis factor inhibitors. And again, so they work to suppress the body's natural immune responses, which is what I've been saying. Right. And they do, there's a number of a biologic mean it was made from a cell, right? This is why, because it was made from cells, that being natural, patients can have allergic reactions to these drugs. But I did list some of those biologic DMARDs for you guys to take a look at, right? uh, let's see. Now, some of the adverse reactions here, these are your immunosuppressant, suppressive drugs. They can lead to nausea, stomatitis, alopecia, or hair loss. And if you think about it, if you look at some of the chemotherapeutic drugs, we know that the primary goal for chemotherapeutic drugs is to kill multiplying or to prevent cancer cells from multiplying. And so, unfortunately, these chemotherapeutic drugs, they kill the good stuff. They kill the good white blood cells, the red blood cells, and the platelets. And so, which will, if you kill the white blood cells, you're in effect suppressing the immune system, right? And so with those particular chemotherapeutic drugs, they cause nausea, stomatitis, as well as alopecia, hair loss. Well, these drugs, because they actually directly suppresses the immune system, they have some of the same symptoms: the alopecia, nausea, stomatitis, and so forth. Right. Now, the adverse reactions to sulfur-based drugs, such as the sulfur salazine, which is one of those DMARD drugs, um, includes ocular changes, the gastrointestinal upset, and also mild pancytopenia. All right. Now, the biologic DMARDs, they also produce flu-like symptoms because they do reduce, again, the immune response. They can also lead to conditions such as tuberculosis, because again, if you suppress the immune system, anything goes just about. The body is just the body's immune system is compromised, and so people can end up with all sorts of diseases. Now, the most common adverse reaction to the drugs given by injection will be skin irritation. In other words, the immune system may react to the drug as a foreign substance, causing redness, swelling, itching, pain at the injection site. Now, now all categories of these DMARD drugs are contraindicated if someone has a known hypersensitivity to the drug. But also clients with renal insufficiency, um, liver disease, alcohol abuse, pancytopenia, and folate deficiency should not take methotrexate, for example, which is one of the DMAR drugs. Women who are pregnant or trying to become pregnant should not use leflunomide, another DMARC drug. The biologic DMARCs should not be used in patients with heart failure, those with neurologic demyelinating diseases such as multiple sclerosis. One of the other drugs called Kineret should not be used in combination with etanercept. Etanercept. Let's see, it's how do you say this one? Adal limumab, adalimumab, and the infliximab. These are some of the craziest names of drugs. Um, the methotrexate, I wanted to kind of touch on why, for example, should not be given to patients with folate deficiency. This drug, for example, methotrexate, it blocks folate metabolism. So methotrexate works by inhibiting what is called the dihydrofolate reductase. And don't get so hooked up on the word. Basically, this is an enzyme that is needed in order for folate, a vitamin, to be metabolized. And so what this drug does is this is the part I want you to focus on. It prevents the body from using folate. Folate is necessary because it helps to make what? DNA, RNA, and proteins. And of course, you ask yourselves, well, why is DNA, RNA, proteins important? One thing, even if you don't know specifically, you do know that DNA, RNA, and of course, proteins are very important. It's essential for our cells to grow and also repair. Right. So that's one of the reasons why methotrexate would be contraindicated if someone has folate. Um, Also, methotrexate, when it talks about it shouldn't be given with patients with renal insufficiency. See, this drug excretes a lot of the metabolites. Once the drug is broken down, the kidneys are necessary to excrete the metabolite of drugs like the methotrexate. But if someone has a renal insufficiency, then this drug it is going to accumulate in the person's body, bringing about toxicity. All right, it brings about toxicity. And I guess the reason why I'm going over some of this is because, we look at some of these. For example, the contraindications or adverse effects, where the author of these books they list them, but they don't really tell you why. And so it is good that you guys do have the ability, especially with ChatGPT, to go back and look at why these drugs do what they do, why they're contraindicated, why should we use precautions, and so forth. Um, it may help you to not have to memorize, but yet know why. For example, with methotrexate, or another example, methotrexate, as we know, again, is a DMARC drug, and it actually suppresses the immune system because remember, an autoimmune disorder is fighting against the body, so we're trying to suppress that autoimmune activity. And so, because it does suppress the immune system, it should not be given to patients with pancytopenia. Remember, with pancytopenia, which is one of the contraindications, all of the blood cells are reduced. Your white blood cells, red blood cells, and your platelets. Well, if the white blood cells are reduced in pancytopenia, and you already given a drug such as methotrexate that suppresses the immune system, it makes the patients, it suppresses the immune system even the more. And what does that mean? It means that these patients they may experience the various diseases even more because they don't have something in their system to help battle a disease causing infections, if you will, or microorganisms, if you will. Um, so it is good to look at um, some of the reasons why they list your contraindications and precautions and so forth. It really helps to or minimizes the memorization. I already talked about this one, so I'll go to the next slide. Um, As far as precautions, this drug should be used with caution in those with obesity, diabetes, hepatitis B or C, who women should not become pregnant while they are on this drug. And also, sexual partners should use barrier contraception to prevent transmission of the drug via semen. So if a male actually has or is on one of these drugs, they should wear protection because this drug is found in the semen, and you don't want the other person, the non-ill or non-sick person, to receive, in essence, receive this drug in their own bodies. So that's the reason why uh, that is the case, right? Uh, let's see. Take a look at the interaction table here. All right. Now let's take a look at bone resorption inhibitors. Remember, these drugs are likely are used rather for women, especially with osteoporosis, other conditions too. But that's one of the main ones that stick out. These are the bisphosphonates, and so let's take a look at their um, actions. But before I get into that, just to give you some incidence and prevalences of osteoporosis, for example, more than 50 million Americans live with osteoporosis. Or they have a low bone mass, or rather, they have low bone mass, which means they are more susceptible to fractures. Osteoporosis involves the loss of bone mass. All right, so the bones become less dense, um, and it is seen typically in women who are postmenopausal, especially because of the fact that they're no longer making estrogen. All right. It is estimated that about 700,000 spinal fractures and almost 300,000 hip fractures occur yearly in the United States because of this condition. Because again, the bones are becoming more weak, less dense, and therefore they're more susceptible to fractures. Now, the bisphosphonates and also some of the newer biologic drugs, they are helping to reduce these fractures, and also those who have a Paget's disease. And Paget's disease is a bone growth and weakening as well. But these drugs are helping to reduce the incidence of these conditions. Now, bisphosphonates act primarily on the bone by inhibiting normal and abnormal bone resorption. Remember, resorption um, basically just means that calcium is being taken from the bone. But these drugs help calcium essentially stay in the bones, which will add to the mass, their density, and their strength. Now, this results when because of this abnormal, resorption issue, it does increase, or rather, these drugs they will increase the density of the bone, and of course, it reverses the progression of the osteoporosis. Now, bone resorption is the process where specialized cells that are called osteoclasts, these are cells, they break down the bone tissue, and this is what is happening in osteoporosis. There's more osteoblast activity than there is, excuse me, there's more osteoclast activity than there is osteoblast activity. Remember, osteoblast meaning the building up of bone, but the osteoclast, it means the breaking down of bones. Now, during this osteoclast activity, the bone's mineral content, especially calcium in particular, is taken away from the bone and it is released into the bloodstream. This is a normal part of bone remodeling because that osteoclast osteoblast is a normal process if it's balanced, because it is remodeling the bone, it's making it stronger, it's taking away the old cells of the bones, and then it's creating new cells and so forth. So this is a good thing, usually. Right, it's that balance between breaking down old bone and forming new cells in the bone. But if bone resorption it becomes greater than the bone formation or osteoblast, it can lead to a decrease in bone density, and then of course these patients they will experience osteoporosis. Now, bisphosphonates are used in the treatment of osteoporosis in postmenopausal women and men. That is caused in particular by some of our glucocorticoid drugs, right? This is because glucocorticoid drugs reduce the body's ability to absorb calcium from the intestines. So, if this drug prevents calcium from being absorbed, then our bones have no access or very little access to calcium, and therefore they become weaker. Also, this drug is given to patients who have hypercalcemia, meaning they have an increased amount of calcium in the blood, which is dangerous. And sometimes this happens due to cancer. Uh, in some, in probably in many ways than not. If ever someone goes to the doctor and they check their calcium levels and they're extremely high, they're likely going to check to see if this patient has cancer. All right. Um, this hypercalcemia can occur due to bony metastasis of some solid tumors. In other words, if the cancer spreads to the bones and it starts to breaking down the bones, then calcium is also going to be released into the bloodstream, and this is not a good thing. Um, So by reducing the osteoclast activity, the drug bisphosphonates, it lowers the amount of calcium that is released from the bones, and thereby helping to decrease the high serum calcium levels. So when we give these particular drugs, especially in patients who cancer is actually causing the release of these bones into the bloodstream, these particular drugs will cause more of an osteoblast situation where the calcium is that is in the blood in high amounts is being added back to the bones and causing the bones to be stronger again. All right. And just for your information, bone resorption is like a cleanup crew for the bones. Osteoclasts are the cells that break down old or damaged bones, and it release important minerals like calcium back into the body where they can be used elsewhere. Because other parts of the body uses calcium as well. Not just the bones, even the heart, it requires use of calcium, if you will. All right. But we're just looking for more of a balance of osteoclast and osteoblast, which is lost in conditions like osteoporosis. Take a look at the adverse reactions. You have the nausea, diarrhea. There's also increased or recurrent bone pain, headache, dyspepsia, and acid regurgitation, um, and dysphagia, as well as abdominal pain. Now, bisphosphonates are typically not issued with clients, uh, um, or rather, I should say, they're typically not an issue when clients are taking the medications the right way. If we instruct them the correct way and they're taking them properly, then um, they normally would not have any issues. And so, as we speak to these patients, we and we're teaching them, we're instructing them. Use the teach back method to see if they truly understand, because as long as they're taking them the proper way, then they shouldn't have much in the way of issues. It actually reduces the adverse reactions. As far as contraindications, these drugs are contraindicated in patients who are hypersensitive to bisphosphonates. Fosamax and Actonel are contraindicated in patients who have hypocalcemia. Because if you think about it, if someone already has a low calcium levels in the blood and use these drugs to add more calcium from the blood to the bones, it's going to cause their serum levels to go down even more. And so you have to be careful. You have to get labs on these patients, in particular these patients, to make sure the calcium levels, the serum calcium levels, meaning the calcium in the blood, we have to make sure that the numbers are normal. Again, you give these medications, otherwise, it'll take more calcium from the blood, and our body needs calcium, not just the bones, but other organs as well. The Fosamax is a pregnancy category C drug, and it is contraindicated. That's pretty high on that level. These drugs are also contraindicated with patients who have a delayed esophageal or have delayed esophageal emptying. In other words, foods they are when you eat and foods are coming down the esophagus, it is delayed before it actually gets pushed into the stomach. So when they have those kind of conditions, this medication would be contraindicated, or if they have renal impairment. All right. Now, the reason so for this, as far as the alendronate, or also called Fosamax, is that in those patients who have delayed esophageal emptying, um, the drug will sit in the esophagus for a prolonged period of time. And these drugs are very irritating to the esophageal tissue, and it can damage the esophagus, right? They're very irritating, right? And it can damage the esophageal tissue. So this medication, it really needs to quickly pass into the stomach in order to be absorbed correctly or properly. If someone again has delayed esophageal emptying, the pill is likely to remain in the esophagus for too long, leading to inflammation. It can lead to ulcers, as well as even strictures. The cardiac um, portion of the stomach. Remember, you have the cardiac portion, cardiac sphincter, and the pyloric sphincter, where the cardiac is more closer to the heart, right? For the top part of the stomach. And so it could cause strictures. And so we have to be careful about that. This is why it's so important to get into a patient's history, um, to ensure that does not become a problem. All right. Now, this is another bisphosphonate drug. The denosumab is associated with hypokalemia, also osteonecrosis of the jaw. Think osteo meaning the bone, and necrosis, death of the jawbone. It can also cause infection, skin reactions, and atypical femoral fractures. And Now, the benefit of the drug versus the harsh and unusual adverse reactions are also being monitored by the FDA in a program that is called Risk Evaluation and Mitigation Strategy, or REMS. With this program, specific instruction and monitoring must occur, and documentation has to be sent back to the FDA regarding the administration of this drug, and the client's knowledge of the potential adverse reactions as well. So this is one of these drugs that is under the REM of the FDA, because they are closely monitoring this medication. I've never heard of them doing this with any particular drug, but probably the pharmacist is more aware of it, perhaps even the physicians. Now, bone resorption inhibitors therapy is also used with caution in women with malignancy, as well as, and of course, we have to consider the benefit versus potential risk to the fetus. The person with a pregnant woman might need it, but it is again used with caution. All right, and this is the interaction table. Take a look at it. All right. Now, so these are your uric acid inhibitors. We have talked about this to a pretty good degree in class. So you should know this is mostly associated with the condition called gout. So gout is a type of arthritis in which uric acid it accumulates in increased amounts in the blood, and then of course um, this substance is then deposited in the patient's joints. Now the deposit or the collection of this urate crystal in the joints is what actually causes the symptoms of the pain and swelling, redness, and the joint deformity of gout. This is what actually causes these symptoms. Allopurinol reduces the production of uric acid, and therefore it decreases the serum uric acid levels and the deposit of uric crystals in the joints. So if I can reduce the amount of uric acid in the blood, then there's a reduction in these crystals being formed in the joints. This probably accounts for its ability to relieve severe pain of acute gout. So even when the patient has an acute episode of pain from gout, this drug seems to be very, um, uh, it works very quickly to reduce that discomfort. One of the newer uric acid inhibitors called Ularic is used to reduce serum uric acid levels, and of course, this can prevent those gout attacks. Now, the exact mechanism of action for the one of the other uric acid inhibitor drugs is called colchicine, but the mechanism of action rather is not known. But it does reduce the inflammation that is associated with the deposit of those urate crystals in the patient's joints. But colchicine has no effect on uric acid metabolism. But again, it does seem to reduce the inflammation and whatnot. Now you have patients, those patients rather with gout. The serum uric acid level is usually again pretty elevated, right? And so in an acute attack, these patients will also be given an infusion of pegloticase, and it may be used to decrease the amount of uric acid in the body as well. One of the drugs, probenecid, it works in the same manner and may be given alone or in combination with a colchicine as a combination therapy when there are more frequent, recurrent attacks of gout. Now, this drug, the profenicid, also has been used to prolong the plasma levels of penicillin as well as the cephalosporins. In other words, they found that this drug it even works with keeping higher levels of antibiotics because maybe the plasma levels will remain more therapeutic in essence. So um, this may kind of turn your mind around a bit or kind of confuse you a bit because we're talking about uric acid, inhibitors, but then now we're talking about antibiotics. Well, again, they're just saying that probably incidentally, they found that when given this uric acid inhibitor drug, that it's been known to keep antibiotic levels at higher levels. And when antibiotic levels are at a therapeutic level, they're more effective against microorganisms. And so really interesting when you think about it. Um, Sometimes that is, an intended effect. In other words, they may place a patient on this particular drug because they're trying to rid the patient of an infection and whatnot. Right. Now, drugs indicated for treatment of gout may be used to manage the acute attacks of gout, also in preventing acute attacks of gout. So it's used as prevention as well. So think about prophylaxis in that regard. It has the uric acid inhibitors. It has an adverse effect on the various systems. On the GI system is the NVD, or nausea, vomiting, diarrhea. Other reactions, headache, urinary frequency, as well as skin rash, and this happens more so with the allopurinol. Some of the more serious reactions is the exfoliative dermatitis. This patient here has Steven Johnson syndrome, but also it can cause severe nausea, vomiting, and bone marrow depression. And more specifically, the Colchinson can depress the bone marrow. And if that's the case, if someone has already um, they're already on other immunocompromised, or rather immunosuppression drugs, giving Colchicine can suppress the bone marrow even the more, meaning the patient is more open up to infections, infection risk, and whatnot. So you have to be really careful with some of these drugs being given with other drugs. As far as contraindications, this drug, if you have a known if the patient has a known hypersensitivity, do not give it. Colchicine in particular should not be given to patients with serious GI, renal, hepatic, and cardiac disorders, and of course those with blood dyscrasias. The phenol, probenecid, SID, is contraindicated with patients with blood dyscrasias as well, uric acid kidney stones, as well as in children who are younger than 2 years old. All right. Now, uric acid inhibitors are used cautiously in those with renal issues and also during pregnancy. These drugs are either a pregnancy category B or C. Allopurinol should be used with caution in those with liver impairment. Probenecid is used with caution in those who have a hypersensitivity to sulfur drugs, as well as peptic ulcer disease. Colchicine is used with caution in older adults. Now, when we talk about the probenecid being used with caution in people who have hypersensitivity to sulfur, it is because these drugs have like the probenecid, have a sulfur like structures within them. All right, and if someone already has an allergy to sulfur, and they're taking a probenecid, then it can cause a reaction as a result. While it is not a classic sulfur drug, this probenecid, there's a potential for cross sensitivity in individuals, again, with sulfur allergies. And so you should be asking these patients, do they have a sulfur allergy? This basically means that some people who are allergic to sulfur drugs may also have an allergic reaction to probenecid. And so be really careful about that. Now, anaphylactic reactions have been seen with pegloticase infusions. Therefore, your drugs such as your antihistamines and corticosteroids are used to pre-medicate these patients before these drugs are given. All right, because remember the antihistamines and the corticosteroids, they can reduce the anaphylactic reaction. So they'll give these two drugs as a pre-medication before they give this IV infusion of the pegloticase infusion. It can just help reduce the anaphylactic reaction. Right. Now, just as a side note, the anaphylactic reaction to this drug, pegloticase infusion, it occurs because of the fact that this drug is actually a biologic agent. And because it's biologic, it's more natural because cells were involved when producing this drug. All right. And because of that, it is a biologic agent. It can trigger an immune response. All right. So that allergic reaction. And just keep in mind, a biologic agent is a type of drug that is made from living cells or proteins instead of being made from chemicals like your ordinary medications, your synthetic medications. All right. And these drugs are often used to treat diseases by affecting the immune system or specific body processes. So, since they come from living sources, they can sometimes cause strong immune reactions like these allergies, anaphylactic reaction, more specifically. And so take a look at I'm actually nearing the end. Take a look at the uric acid inhibitors here and here, and this is where we stop. So go ahead and take a look at the pre-admission assessment. Let's see if there's anything that sticks out. If you guys need to turn off from this point, that's fine. But I just want to kind of look through this quickly. So there's the description of signs of immobility because we are dealing with these joint issues that affect immobility. So we want to get a baseline for that. See if there's any improvement down the road. If there are any effects of change in activities of daily living, because that's what joint issues do. They affect our ADLs. Description of affected joints in the extremities. What is their appearance over the joints? Is there evidence of joint deformity or signs of immobility? Uh-oh. Laboratory tests and bone scans to measure bone density because we're trying to see if there's an improvement. We should also do a tuberculin test with those who are receiving biologic DMARDs, because remember, this drug, it reduces the immune system. And so these patients are susceptible to tuberculosis. And so we want to check and make sure that they're not experiencing tuberculosis or have been exposed to it. Let's see if there's anything here. Health history, immunocompromise, or travel to areas with infectious diseases. Remember, these patients who are on DMARDs, they are immune compromised, right? It's no different than a person who's on a steroid or any of the other immunosuppressant drugs if they have an organ transplant. These patients also are in a similar circumstance. Let's see, ongoing assessment, gout, so inspect the joints involved every 1 to 2 hours to identify immediately a response or a non-response to treatment. Question the client regarding relief of pain, adverse reactions, and so forth. That's a question. These are the important nursing diagnosis. Readiness for enhanced fluid balance related to the need for increased fluid intake to promote excretion of uric crystals. So we are trying to, some of these drugs are given to excrete more of the uric acid so that these crystals will not form. So that is an appropriate nursing diagnosis. Impaired comfort, gastric distress related to irritation of gastric lining from medication administration. This is especially the case with the which drug was that? It slipped my mind already. Anyway, one of the drugs that we were talking about, the esophageal emptying, delayed esophageal emptying. We need that drug to progress through the GI tract for absorption as quick as possible. Otherwise, it'll cause irritation and ulcers and what have you to the esophageal tissue. Injury as well as risk rather related to response to substance trigger a drug allergy. So these are all appropriate. And make sure you read your textbook regarding what the nursing interventions are and outcomes and so forth. Go ahead and read your planning, um, promoting optimal response to therapy. So how do we do that? Clients may have long-standing chronic pain and joint deformities, and so medications are used for management. But the nurse should encourage the patient to rest, to also participate in physical therapy because that can also help with mobility, and teach the patient that therapeutic regimen is getting the client to a tolerable level of pain. In other words, they will still have pain, but the pain would not be as such that it causes immobility. That some of us, we know we walk around and we still have pain, but it is fine as long as it doesn't prevent us from moving about. And so if the patient does not have the ability to walk about because of increased pain, then the medications need to be reassessed by the clinician. All right. Clients assist clients to deal with emotional response to chronic conditions. There's a heavy emotional response on these types of patients because they have this condition day in and day out and probably for the rest of their lives. Educate client that benefit of drug may take weeks or longer to notice. So some patients might be a little impatient, and so you have to let them know, hey, this may take a few weeks, a few months, and so don't be discouraged. In other words, be alert to adverse reactions such as skin rash, fever, cough, or easy bruising. Be attentive to specific client complaints such as visual changes, tinnitus, and hearing loss and so forth. And so always want to know what the client reactions are to these drugs so that we can address them accordingly. Let's see, report any findings of potential severe adverse reactions, as especially the SJS when clients are on allopurinol. This is a really important one here, as they all are, but this one is really important. Monitor labs closely for clients who are taking methotrexate for signs of thrombocytopenia, or low platelets, or leukopenia, low white blood cells. Hematology, liver, and renal function tests are done every 1 to 3 months because these drugs they do affect these different components of the blood. So patients should be encouraged to keep these appointments and to be monitored so that, may have to take away some drugs, may have to add drugs, may have to adjust dosages. And so we don't know that unless patients are following up accordingly. Encourage a liberal fluid intake and measure the intake and output. Output should be about 2 liters. All right. So they should be peeing at least 2 liters. Consider supplemental IV fluids if the client fails to drink 300,000 fluids per day. That may be pretty difficult in the community setting when they're at home. But of course, in the hospital, we can always add IV fluids and help increase the IV fluids so as to excrete the uric acid, for example. Here, as far as impaired comfort, patients who experience gastric distress, to facilitate the delivery of the bone resorption inhibitors to the stomach and minimize GI effects. Administer the drugs with about 6 to 8 ounces of water directly upon waking. while the client is in an upright position. Being upright can help facilitate movement of that drug throughout the GI system. So not lying down, but sitting up. Nobody should be eating or taking anything lying down, right? And these clients should remain upright for 30 minutes. This is testable material, folks. The edidronate is not administered with food, vitamin, and mineral supplements or antacids. So it should not be given with anything, it appears. Risk for injuries. Many of these drugs cause drowsiness, pain, and deformity, and pain and deformity can hamper mobility. So these patients should be cautioned against when they're taking these drugs and what it can lead to. Evaluate the clients carefully before allowing them to ambulate. All right, and notify the primary care doctor before the next dose, especially if drowsiness is severe. All right, because this can add to the severity even the more, to the point where the patient might not be safe. Um, assist with ambulatory activities if drowsiness does occur. Clients on bed rest need to be turned at least every 2 hours. And clients with osteoporosis may need a brace or corset when out of bed, especially if you don't want when you want to minimize fractures and whatnot. And anyway, so I'm going to let you guys read the rest of it. I mean, again, this is what we have pretty much covered already. This is really important. Keep resuscitation equipment nearby in case of anaphylaxis. Remember, with anaphylaxis, it can cause swelling of the upper airways, and these patients will have a airway. The airway is compromised, leading to a cold. And so, just read the rest of this information. This is pretty much at the end. Um, Explain that the drug can cause drowsiness to avoid driving or doing hazardous tasks. We talked about all that stuff. All right. Um, all right. So just read the rest of this information and just relate it back to what we talked about already. We're in the implementation phase of the nursing process, by the way. We evaluate, we always evaluate, and that is it. That is it. All right. Oh, I'm trying to come out of this. Oh, there it is. All right, folks, I'm going to stop sharing here and I will get this over to you. It was a little longer than I expected, an hour and 13 minutes, but you can speed it up on the YouTube platform. Let me know what you all think. Thank you.